Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by our senior colleague, Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of Nath Arua and the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 387 of our pharmacotherapy series, which majors in seizure disorders. My first question to you reads, PAR is a 14-year-old, 40-kilogram female high school student. PAR had 3 febrile seizures when she was 3 years old. She received phenobarbital prophylaxis, off and on, according to her parents, for about 6 months after her second febrile seizure. Since then, she had no reported seizures until 24 hours before admission. At that time she had a convulsion shortly after arriving at school in the morning. A teacher who witnessed the episode describes her as behaving oddly before the seizure. She abruptly got up from her desk and began to walk clumsily toward the door. She bumped into several desks and did not respond to the teacher's attempts to redirect her back to her seat. After approximately 1 minute of this behavior, she fell to the floor and experienced an apparent generalized tonic-clonic seizure that lasted approximately 90 seconds. During the episode, she was incontinent of urine and was described as turning kind of blue. After this episode, PAR was transported to the hospital. On arrival at the hospital, PAR appeared drowsy and confused. Laboratory studies including a complete blood count, abbreviated as CBC, serum glucose, electrolytes, drug and alcohol screen, and lumbar puncture, were normal. Physical examination and a complete neurologic evaluation were normal. An EEG showed diffuse slowing with focal epileptiform discharges in the left temporal area. It was interpreted by the neurologist as abnormal. There was no history of recent illness or injury, although PAR had stayed up late several nights recently studying for an examination. A second seizure occurred in the hospital. The nursing staff described an episode similar to the one that occurred at school. After recovery from each episode, PAR had no memory of events during the seizures. She only remembered a funny feeling in her stomach and a buzzing in her head before she lost consciousness. She described having these feelings a couple of times in the past. She attributed him to just getting dizzy and had not reported him to her parents. After these previous episodes, PAR described feeling mixed up and groggy for a few minutes. So my question to you is, what subjective and objective features of PAR's seizures are consistent with a diagnosis of complex partial seizures with secondary generalization? PAR's clinical pattern of observed seizure activity, an apparent aura preceding her loss of consciousness, a history of apparent complex partial seizures not accompanied by generalized seizures, and the findings of focal abnormal activity on EEG are all concordant with this diagnosis. Postictal confusion and grogginess are common after both generalized tonic-clonic and complex partial seizures. Her unusual or inappropriate behavior represents a complex partial seizure that subsequently generalized. The clinical features, accompanied by her EEG findings, also help rule out possible atypical absence seizures, which can be confused with complex partial epilepsy syndromes based on only clinical presentation. In both syndromes, patients may briefly appear to lose contact with their surroundings and display automatisms and mild clonic movements during seizure activity. In PAR's case, the EEG and the generalized tonic-clonic seizures during her episodes would rule out atypical absence as a likely possibility. The next question reads: what factors should be considered in a decision to treat PAR's seizures with anti-epileptic drug therapy? Once a diagnosis of epilepsy is established, the decision to treat the patient with medication is based on the likelihood of recurrence. The need for anti-epileptic drug therapy after a single seizure is controversial, but according to the 2015 evidence-based guideline on this topic, patients should be informed that their seizure recurrence risk is greatest early within the first 2 years, and starting of anti-epileptic drug therapy is likely to reduce recurrence risk within the first 2 years. In PAR's case, the potential benefits of immediate introduction of anti-epileptic drug therapy appear to outweigh potential risks. She experienced complex partial seizures, and some were followed by secondarily generalized tonic-clonic seizures. Recurrence of seizure activity is likely to result in physical injury, social embarrassment, and interference with her participation in activities typical of a person her age. If her seizures are not controlled, she faces future limitation of her driving privileges and may face barriers to employment. Although anti-epileptic drug therapy is associated with risks, they probably are outweighed by the potential benefits. My next question to you reads: which anti-epileptic drugs are commonly used for PAR's seizure type? Based on the subjective and objective data available, recommend a first-choice anti-epileptic drug for PAR and a plan for initial dosing of this medication. Many anti-epileptic drugs would be appropriate choices for PAR's complex partial seizures that can secondarily generalize. Some anti-epileptic drugs are not FDA approved as initial monotherapy. Although valproate is effective for treating both generalized and complex partial seizures, it would not be a good initial choice for this patient owing to the increased risks in a woman of childbearing age. Eslicarbazepam, ezogabine, felbamate, gabapentin, lacosamide, lamotrigine, levetiracetam, oxcarbazepine, perampanel, pregabalin, tiagabine, topiramate, and zonisamide are effective for control of partial seizures with or without secondary generalization. Most experience with these drugs was obtained when they were used as adjunctive agents when previous anti-epileptic drug therapies were unsuccessful. Initial clinical trials with these medications indicate that several of them may be useful as single agents. Felbamate, lacosamide, lamotrigine, oxcarbazepine, and topiramate have monotherapy indications. Most of the more recently approved medications appear to be safe and are usually well tolerated. The usefulness of felbamate is limited, however, owing to its potential for serious hematologic and hepatic toxicity. Carbamazepine has several advantages that make it a preferred first-choice agent in the opinion of many clinicians. In comparison with phenytoin, carbamazepine is less sedating and is not associated with dysmorphic effects, such as hirsutism, acne, gingival hyperplasia, and coarsening of facial features. Carbamazepine's pharmacokinetic profile also makes dosage adjustment easier. In PAR's case, the lack of cosmetic side effects may be especially significant because she may be taking medication for many years. In addition, reduced sedation may be important with respect to her school performance. We will now briefly talk about carbamazepine therapy. Initiation and dosage. Initiation of treatment with full therapeutic maintenance doses of carbamazepine often causes excessive side effects such as nausea, vomiting, diplopia, and significant sedation. Therefore, carbamazepine therapy should be initiated gradually and patients should be allowed time to acclimate to the effects of the drug. Final dosing requirements are difficult to anticipate in individual patients. A reasonable starting dosage of carbamazepine for PAR would be 100 mg twice a day. Her dosage could be increased by 100 to 200 mg per day every 7 to 14 days. The rapidity of increases will depend on PAR's tolerance for the drug and the frequency of her seizures. Carbamazepine has been associated with hematologic and hepatic toxicities. So my question to you is, what is the incidence and significance of these toxicities? How should PAR be monitored for them? Aplastic anemia and agranulocytosis have occurred in association with carbamazepine therapy. Several cases have been fatal. However, most cases occurred in older patients treated for trigeminal neuralgia. Many patients were receiving other medications, and occasionally the reports were incomplete. Thus, assessment of a causal role for carbamazepine is difficult. Severe blood dyscrasias from carbamazepine seem rare. The estimated prevalence is below 1 in every 50,000, and have predominantly occurred in non-epileptic patients. The lack of severe hematologic toxicity in various published series and clinical trials in patients with epilepsy has been notable. Leukopenia is relatively common in patients taking carbamazepine. It is usually mild and often reverses despite continued administration of the drug. Total leukocyte counts may fall to less than 4,000 cells per microliter in some patients, but differentials and platelet and erythrocyte counts remain normal. Symptoms, e.g., fever, and sore throat, that might suggest early stages of agranulocytosis do not occur. Carbamazepine-associated hematologic disorders are unrelated to drug dosage. Thus, these reactions appear to be idiosyncratic. We will now briefly talk about routine hematologic testing. Laboratory monitoring of PAR's hematologic status is recommended during carbamazepine therapy. The likelihood of early detection of aplastic anemia or agranulocytosis through frequent blood counts is low. However, and such monitoring is costly. Because hematologic toxicity from carbamazepine primarily occurs early in therapy, a CBC should be obtained before therapy and at monthly intervals during the first 2 to 3 months of therapy. Thereafter, a yearly or every other year CBC, white blood cell count with differential, and platelet count should be sufficient. Regarding hepatotoxicity, carbamazepine-related liver damage is extremely rare, despite its being frequently mentioned as a potential problem and strong warnings in the package insert. Hepatic adverse reactions are believed to be idiosyncratic or immunologically based. Aggressive laboratory monitoring of liver function tests, abbreviated as LFTs, probably is unnecessary. Alkaline phosphates and gamma-glutamyl transferase concentrations often are elevated in patients taking carbamazepine and other anti-epileptic drugs. This is believed to result from hepatic enzyme induction and is not necessarily evidence for hepatic disease. In summary, hepatic and hematologic toxicities of carbamazepine are rare. Although potentially serious, they are best monitored on clinical grounds rather than by ongoing, intensive laboratory testing. Patients, families, or caregivers should be aware that the appearance of unusual symptoms, e.g., jaundice, abdominal pain, excessive bruising and bleeding, or sudden onset of severe sore throat with fever, should be reported to a healthcare professional. Baseline, that is pre-treatment, determination of PAR's hepatic and hematologic status, possibly with monthly follow-up testing for 2 to 3 months, probably will be sufficient. Thereafter, a CBC and a liver function battery should probably be evaluated only every 1 to 2 years, unless signs or symptoms of hepatic or hematologic disorders are observed. For the subsequent 6 weeks, PAR's carbamazepine dosage was gradually increased to 400 mg twice daily dosed at 20 mg per kilogram per day. Until the last dose increase, she had been experiencing 1 or 2 complex partial seizures weekly. She had experienced only 1 generalized tonic-clonic seizure since her hospitalization. 1 week after the increase to 20 mg per kilogram per day, her serum carbamazepine concentration was 9 micrograms per milliliter just before her first dose of the day. No seizures occurred for 4 weeks, and she tolerated the medication well. Subsequent to the 4-week seizure-free period, she again began experiencing 1 seizure weekly. So my question to you is, what factor or factors might be responsible for this reversal of seizure control? Several factors may account for this change. It is important always to consider the possibility of poor medication adherence when clinical response changes unexpectedly. This should be investigated, and PAR and her family should be educated regarding the importance of regular medication intake. The observed changes in PAR's seizure control may also be due to unique features of carbamazepine pharmacokinetics. Carbamazepine is a potent inducer of hepatic cytochrome P450, abbreviated as CYP3A4. The drug is also a substrate for this enzyme. As a result, carbamazepine not only stimulates the metabolism of other CYP3A4 substrates, but also induces its own metabolism by autoinduction. Carbamazepine's half-life after single acute doses is approximately 35 hours. With chronic dosing, its half-life decreases to 15 to 25 hours. This increase in clearance necessitates increased carbamazepine doses, increased frequency of administration, or both. Autoinduction of carbamazepine metabolism appears to be related to dose and serum concentration. Approximately 1 month may be required for the autoinduction process to reach completion after each increase in carbamazepine dose. Assuming that adherence was not the main problem, PAR's carbamazepine dose should be increased. The drug's pharmacokinetics are generally linear with respect to acute dosage changes. A 50% increase in dosage to 1,200 mg per day should re-establish seizure control. Depending on PAR's clinical status, further increases in dosage may be necessary. PAR's dosage was increased to 600 mg twice daily. 4 weeks later, she was still experiencing approximately 1 complex partial seizure weekly. A repeat trough serum carbamazepine concentration was 6.5 micrograms per milliliter. On questioning, PAR denied missing doses of medication, and a tablet count confirmed apparently accurate drug intake. PAR relates that she experiences some mild nausea after her doses, but she has not vomited. It is noted that her pharmacist has begun substituting a generic carbamazepine tablets for the Tegretol that was previously dispensed. So my next question to you is, what role, if any, might this change in carbamazepine formulation have played in the failure of PAR's serum concentrations to increase as expected? What other factors might be considered in explaining this situation? Several manufacturers market generic carbamazepine tablets. Bioavailability data supplied by the manufacturers are based on single-dose or short multiple-dose studies in healthy subjects. Therefore, it is impossible to completely predict the results of a change from Tegretol to generic carbamazepine for maintenance therapy in an individual patient. Because of variations in amount of drug available from different products, some patients with epilepsy, also known as generic brittle, cannot tolerate changes in formulations between brand and generic, generic and generic, or generic and brand. Changes in seizure control from too little drug or toxicity from too much drug have been reported with changes between formulations for several anti-epileptic drugs. On the other hand, 2 recent in-depth bioequivalence studies have found no evidence to support any pharmacokinetic differences between brand and generic products of lamotrigine in patients with epilepsy. Bioavailability data suggest that the generic carbamazepine preparations currently on the market may be substituted for Tegretol with little need for dosage adjustment. Nonetheless, in PAR's case, substitution of generic carbamazepine may be a possible cause for the loss of seizure control. Readjustment of her dose to gain seizure control and consistent use of one manufacturer's product, either brand or generic, might alleviate this problem. 3 extended-release forms of carbamazepine, that is Tegretol X, R, Carbatrol, and Equetro, are available and may provide an alternative for PAR. These formulations allow more reliable absorption of drug when administered on a twice-daily dosing schedule. Many patients can better tolerate carbamazepine when these forms are used because large fluctuations in plasma concentrations are avoided. Use of Tegretol XR to avoid 3 times daily or 4 times daily dosing schedules has been shown to increase adherence for many patients. It is important to counsel patients on the fact that the empty osmotic controlled release oral delivery system tablet shell from the Tegretol XR dose does not dissolve as it passes through the gastrointestinal tract, and it may be visible in the stool. Patients need to understand that the carbamazepine has been absorbed, and that this is an empty shell. Tegretol XR tablets lose their extended release properties when broken or crushed. Carbatrol beads may be emptied onto food or administered via feeding tube. Aquetro is not FDA approved for epilepsy. It is indicated for the treatment of acute manic and mixed episodes associated with bipolar I disorder. In conclusion, it may be impossible to identify a single cause for the unexpected change in PAR's seizure control. Common reasons for loss of seizure control include sleep deprivation, increased stress, acute illness, and/or medication non-adherence. So there you have it. Our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. On behalf of our senior colleague, Dr. Nath Arua, I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 388.